Hello, this is Dr. Chandana Vishwanatham. Today, in this video, I'll be talking about MCQs that are frequently asked in MRCP regarding COPD. So, going into the topic, so this is a simple question that can appear in MRCP Part 1. This is mainly given when they want to test your basic knowledge. So it is a 67-year-old obese man with COPD presenting in a drowsy state, unable to rouse him, and good level of function. He usually has a good level of function and uses salbutamol inhaler and smokes 5 cigarettes per day. Urine chest X-ray and blood gases, it is showing pH is 7.2, which is acidic pH, and PCO2 is 8.7, which is higher. Normal PCO2 is 4.626, and this value is higher. And the PO2 is 6.3 kilopascals, where it is showing hypoxia, and bicarbonate is within the normal range. So this ABG is given, and which of the following best describes the blood gas results? So this is just an interpretation of the ABG. Along with this, there is a COPD patient. So if you can recall the causes of respiratory acidosis that I have explained in my first video in respiratory system, I told that obstructive lung diseases are the most common cause of these respiratory acidosis. And this picture also fits into respiratory acidosis because if for it to be called as metabolic acidosis, the bicarbonate should be less, but it is in normal range. So these two options are ruled out. And fully compensated respiratory acidosis is when the pH becomes normal, but here the pH is acidotic, so it is not compensated yet. And due to high PCO2, there is evidence of respiratory acidosis. So this can be the correct option. And metabolic alkalosis is when the bicarbonate is higher. So this is not the thing in this case. The correct option is respiratory acidosis. So this is a simple MCQ that can appear in MRCP Part 1, but don't overthink this kind of MCQs. There are some simple MCQs that can be asked, and sometimes you may overthink and put another wrong option. So don't do that. Going to the next MCQ, please pause the video and try to read the MCQ and write down the option that you think the answer is, and then play the video again. So that will be an exercise for you rather than just watching the video. So here is a 35-year-old patient presented with a productive cough and shortness of breath on exertion over the past month, and has no personal past medical history, but his father suffered hepatocellular carcinoma at younger age, and he's a smoker of 10 back years, and on examination there is hyperexpanded chest and bivasal V's. This is simple interpretation of the spirometry that we need to do here. So the FEV1 is 54% predicted, so which is very low. If 100% is a predicted value, from that the percentages are calculated in the questions. So 54% is very low, still very less, significantly reduced. FVC is 82%, and residual volume is preserved, and this means that there is an obstructive airway disease and air trapping is there, and TLC voice transfer factor is low. So this fits into emphysema rather than asthma, because in asthma the transfer factor will be high, but here the transfer factor is given low. The transfer coefficient is also low, so this fits more into an emphysema rather than asthma. And the options given here are asthma, emphysema, lymphangitis, carcinomatosis, thoracic cage deformity, and slowly expanding pneumothorax. So emphysema would be the likely answer here. And but the patient is presented over 35 years of age, and only the history is from 1 month, so it is rapidly progressing. And with the family history of hepatocellular carcinoma, we can suspect the patient to have alpha-1 antitrypsin deficiency, and as he is smoking, this smoking can cause rapid worsening of alpha-1 antitrypsin deficiency patients, and they can present with emphysema early. So this could be the case. So going to the next MCQ. You are seeing a patient in a clinic. Unfortunately, all clinical notes have been given for audition, and this is also a simple interpretation of our pulmonary function test. So just pause the video and try to answer it. The FEV1 is 0.3. That is, if 1.2 is taken as a normal thing, it is less than 30%. So the FEV1 is significantly reduced and total lung capacity is 6.8, which means it is preserved, and the corrected transfer factor is TLCO. As I told, it will be low in emphysema. So this is making it clear that it is emphysema. But here there are two options: very severe and moderate. For this, you have to, if you have not seen my video on COPD guidelines, please see. There I have explained about the levels of severity, where FEV1 less than 30% predicted is given under very severe chronic obstructive pulmonary disease. So this will be a correct option for this case. So there is another MCQ. 76-year-old man with 10-year history of COPD, with his 2-day history of progressively worsening dyspnea, cough, started on home oxygen therapy for 12 hours per day and nebulizers. His breathlessness on minimal exertion, and he's rarely leaving the house. Several exacerbations per year, requiring hospital admission, and become more frequent over the last few years. And he stopped smoking 2 years ago. The respiratory rate is 32. Auxiliary muscle of respiration are being used. Pulse is 120. There is tachycardia and there is high blood pressure. The patient is able to speak in broken sentences. Auscultation of the chest revealed generalized poor entry and expiratory wheeze. His chest radiography. So let's see the chest X-ray. So this is the chest X-ray, which is showing a hyper-inflated lung fields and flattened diaphragm and a narrow heart. So this is suggestive of emphysema. So coming to the ABG values when he came to the hospital, so the pH is 7.32, which is less than 7.35 obviously, and the PaO2 is 6.2 kilopascals, which means there is hypoxia, and PCO2 is 7.2, which means there is respiratory acidosis in this patient. His inspired oxygen concentration was increased to 28%, and he was treated with a hydrocortisone, salbutamol, ipratropium, aminophylline infusion after 1 hour. He made little improvement and was tired. So a repeat ABG was done, which is showing further fall in the pH, which is 7.26, and PaO2 is almost the same. There is hypoxia and there is increase in respiratory acidosis. This is the important thing that you have to note down, because this is very life threatening. Hypercapnia is very life threatening. So what is the next most appropriate management step in this patient is the question. So remember, if you remember, I've told NIV and intubation based on pH values. So in this case, the pH is 7.26. So I told you, so consider NIV when the pH is 7.25 to 7.35, and if the pH is less than 7.25, go for intubation. So let's see the options. Immediate intubation ventilation, this is not the correct option. Intravenous toxopram, this is not a correct option. So BiPAP will be the correct option here, because the patient's pH is more than 7.25, I mean less than 7.25. We have to go for intubation, but in this case it is 7.26, so we can go for bilevel positive airway pressure. And CPAP, I told you that it is used more in pulmonary edema rather than COPD, so this is the better option here, bilevel positive airway pressure. So you are asked to comment on some ABG. You understand the sample was taken from 64-year-old patient, and she's a female, she's a smoker, and she came with shortness of breath, wheeze, and on auscultation investigations reveal the following. So here they just want you to answer the MCQ, like they want you to diagnose the condition. Options here are diuretic therapy, because of diuretic therapy, Bartter syndrome, chronic COPD, acute exacerbation of COPD, Conn syndrome. So these are the options. We have to diagnose the patient based on the ABG. So the pH is normal. There is PCO2 retention 6.5, which means it could be respiratory acidosis. And the PO2 is the patient is having hypoxia. So bicarbonate is 38, which means the patient is trying to retain bicarbonate, which is alkali, to counteract the respiratory acidosis. So by retaining the bicarbonate, the patient is able to compensate his pH, but there is presence of underlying respiratory acidosis is there. In acute exacerbation of COPD, it will be difficult for the patient to bring the bicarbonate to such higher value and compensate his respiratory acidosis. It is only possible when the patient is having chronic COPD. in chronic COPD, as it is a slow process, the patient will be slowly building up his bicarbonate levels and it will increase and the pH becomes normal. So this is only possible in chronic COPD. So this is another MCQ. 73-year-old man with severe COPD managed with steroid, hydrosteroid, LABA inhaler. He is admitted to the ER. He suffers from increasing shortness of breath, worsening cough the past few days, is now completely unable to get his breath. So this is acute exacerbation of COPD, and his pyrexial chest signs are consistent with right side consolidation and pulmonary edema. He looks tired and his respiratory rate has fallen to 13. This means that there is right side consolidation. There is pneumonia which has triggered his COPD exacerbation, and respiratory rate is falling, which means the patient has respiratory muscle fatigue, and he may land up in hypercapnia in near future. So investigations reveal the following: this is hemoglobin and fluid cells, platelets, everything is given. There is electrolytes and creatinine, CRP, and chest X-ray showing right-sided consolidation with evidence of pulmonary edema. So let's see what they're asking. So blood gases are controlled. On controlled oxygen we have 40% venturi. Reveal the following. So this is the APJ, and what is the most appropriate way to manage his oxygen replacement is what has been asked. So the patient's pH is 7.28, PO2 is 7.8, PCO2 is 7.1. There is hypercapnia in this patient. So again, the similar MCQ that we have told before. So as there is hypercapnia, we need to go for we need to consider NIV, and the pH is also between 7.25 to 7.35. So BiPAP will be the best option here. So there is another MCQ there where 49-year-old nurse comes to the surgery. She's a smoker, 20 cigarettes per day, complaining of increased shortness of breath, chronic cough, wheezing, and she smells strongly of cigarettes. And you can hear wheezing and occasional crackles and auscultation, which is the most useful thing to determine appropriate long-term management of her condition. So here they are asking for appropriate long-term management, which is mainly determined uh, by diagnosing the condition. So we need to diagnose this condition. She is a smoker and she came with shortness of breath, chronic cough, and wheezing. So the first differential would be chronic obstructive pulmonary disorder. So what is that? Is that is used to diagnose COPD. This chest X-ray is not diagnostic. Alpha antitrypsin deficiency is not diagnostic. CT thorax bronchoscopy. All these are not diagnostic tests for COPD. Spirometry with reversibility is a diagnostic test that you can tell if the patient is having a COPD or not, which means the post bronchodilator FEV1 by FVC ratio should be less than 70%. So this is the appropriate test that we can do. And in patients who are reversible, there is good evidence for treating with inhaled corticosteroids in asthma. So and spirometry also correlates well with long-term mortality and can be helpful in persuading patients to give up smoking. So this could be an appropriate investigation to do. Spirometry is the diagnostic test for COPD. So this is a 67-year-old man with severe COPD, stopped smoking 3 years ago. History of myocardial infarction, chronic peripheral vascular disease. They have given some his medications, which include ramipril, indapamide, salbutamol, ipratropium, and which are the following clinical features which would best support the prescription of long-term oxygen therapy. So if you have not seen my previous video on extra adjunct COPD, please go back and see the video, because it is very, very important. Long-term oxygen therapy is being repeatedly asked these days. So if you can recall what was the indication for long-term oxygen therapy. Either the patient should have either PaO2 less than 7.3 kilopascals, or the patient should have PaO2 ranging from 7.3 to 8, along with some other clinical features such as peripheral edema, polycythemia, or pulmonary hypertension. So let's go into the options. PaO2 of 8.2 is not an indication. Less than 7.3 is an absolute indication, but 7.3 to 8, if there is presence of the 3 P's, which mean peripheral edema, polycythemia, pulmonary hypertension, then you can go for LTOT. But 8.2 is very unlikely that we give this patient LDOT. Pitting edema of the lower limbs, this is a feature of pulmonary hypertension, so this can be the answer. PaCO2 is not irrelevant to the long-term oxygen therapy. It is not given in the indications to include this. FEV1 is also not included in the indications. The history of angina is irrelevant. So pitting edema of the lower limbs is an indication for long-term oxygen therapy. So here is a 54-year-old man with COPD attends smoking cessation advice. Which of the following methods is likely to be associated with greatest chance of quitting? So here the options of bupropion, nicotine replacement lozenges, willpower, nicotine replacement gums, or hypnosis. So these were obviously not the correct answers. So here we need to compare bupropion with nicotine replacement therapy. So there are some studies that suggest bupropion has a success rate which is more than the nicotine replacement therapies. So this can be the correct option. Bupropion is the correct option. When there is an option of varenicline in the options. Uh, so varenicline in combination with motivational support has a higher quit rates compared to bupropion. So if there is varenicline, we can go ahead with varenicline. But clinically, when we are prescribing these medications, we are supposed to not favor any one of them according to the NICE guidelines. But there are some studies which suggest the quit rates of bupropion are higher than nicotine replacement therapy. So the answer can be bupropion here. So a 69-year-old woman with COPD managed with in high-dose inhaled corticosteroids, salmeterol, tiotropium. So she's using triple therapy and come to the emergency with infectious exacerbation. There is cough, yellow sputum, and cough, shortness of breath. She's unable to mobilize more than few meters. On examination, she is pyrexial. The pulse is 90. There is atrial fibrillation. Blood pressure is normal. Bilateral wheeze and poor air entry and auscultation of her chest. Investigations in ABG analysis were done after antibiotics. 1 hour of back-to-back nebulizations and hydrocortisone were given. After which the ABG is done. So let's go into the investigations. So in these investigations, there is slight rise in the creatinine, and the pH is acidotic, which is respiratory acidosis, because the PCO2 is more than 6, which is 8. So the patient is having respiratory acidosis and there is hypoxia. So what is the question? Which of the following is the most appropriate next step? So the patient is already given therapy with antibiotics, back-to-back nebulizers, and the steroids also. So even after that, the patient is not having improvement in her pH and CO2 retention. So it is better we go for an NIV, which is non-invasive positive pressure ventilation. Thus the pH is between 7.25 to 7.35. So this is similar to the previous MCQ. Here, 64-year-old woman comes to respiratory clinic for review. Recently diagnosed with moderate COPD and about to commence therapy for her condition. She also has history of hypertension, chronic stable angina, and she's on ramipril indapamide diltiazem. BP is 130/80 and pulse is 70. There's bilateral poor air entry with quiet wheeze on auscultation of the chest. So, which of the following has the greatest short-term impact on her quality of life in the next 2 to 3 months? So, quality of life. As we are speaking about quality of life, the pulmonary rehabilitation is an important thing because it has shown to improve exercise tolerance in COPD patients, and it will also improve exercise tolerance in relation to her chronic stable angina. So compared to other options, this will be an ideal thing to offer. So coming to the other options, ipratropium is a short-acting anticholinergic. There is no significant impact on quality of life in COPD. Long-term oxygen therapy, this can be a beneficial thing in long-term, changing her long-term impact of her quality of life, because this can reduce the chances of progression of pulmonary hypertension and right heart failure over long term. But they have asked greatest short-term impact, so this is not an ideal option. And salbutamol is a beta agonist, and it doesn't have any effect on its quality of life in COPD. Tiotropium, similar to the epitropium I have discussed. So pulmonary rehabilitation helps in improving the short-term quality of life in this patient. So I have taken this MCQ because I want to tell you the importance of COPD management. The flowchart that I have shown in the previous video of COPD guidelines, the flowchart is very important. They can stop you anywhere and they can ask you the next line of management. So let's go into the question. 71-year-old woman with diagnosis of COPD is referred for further management. So she has 3 hospital admissions with exacerbations and requiring systemic corticosteroids in the last 7 months. So she has been taking salbutamol as and when required, although her exercise tolerance is severely impaired. The blood pressure is 150/90 and 75 beats per minute. Atrial fibrillation is there. Hyperexpanded with emphysematus changes. Bilateral poor air entry and quiet wheeze. So this is important. Her peak expiratory flow rate is 40% of predicted, and she has raised eosinophil count. So if you can recall the flow chart, the first line of management will be SABA or SAMA, and then we have to look for steroid responsiveness, which is raised eosinophil count, and here the peak expiratory flow rate is 40% of predicted, but I have told you that there should be a substantial diurnal variation in peak expiratory flow, at least 20%. So if you have measured 2 times in a day, there should be variation variation of 20%. So this is not a point that can give us any clue, but this raised eosinophil count can give us a clue that there is steroid responsiveness in this patient. So the most appropriate management plan would be inhaled steroids with salmeterol. Salmeterol is a long-acting muscarinic agonist. So in the flowchart, the next would be LABA with ICS. So even if after starting LABA with ICS, if the patient has uncontrolled symptoms, then we can go for triple therapy, which is LABA, LAMA plus ICS. So this is next MCQ. Try to pause the video and try to answer it. So this is 63-year-old man who comes to the respiratory clinic for review. He's a COPD and 40-year back history of smoking. And what is the important thing here? Despite taking salbutamol inhalers 4 to 5 times per day, significantly short of breath and has dry cough, can walk only 30 minutes and only climb stairs once a day. Blood pressure is fine and pulse rate. Chest is hyperexpanded, air entry is poor, there is fine wheeze on auscultation, lung function test showed FEV1 of 30% predicted with no evidence of reversibility. So what is the appropriate next step? So in this question, there is nothing suggestive of steroid responsiveness. So here they have given no evidence of reversibility, but now this is not in COPD, this is not considered or not routinely done. The reversibility, bronchodilator reversibility test is not routinely done. Only based on 4 things you see the steroid responsiveness, as I've explained in the previous flowchart. So there is, other than this reversibility, there is nothing here to suggest steroid responsiveness. So we can directly go for LAMA plus LABA inhaler, which is the first option, as the patient is already on SABA. Where is it? Yeah, here. As the patient is already on SABA, we can go for LAMA plus LABA. Only if the steroid responsiveness is clearly mentioned in the question, only then go into inhaled corticosteroids. If you have any doubt, or if you feel there is nothing supporting steroid responsiveness, go ahead with LAMA plus LABA inhalers. And if the patient is having uncontrolled symptoms, even with LAMA plus LABA, then we can go for triple therapy. This one, LAMA, LABA, and ICS. So the next MCQ is a 60-year-old man who was diagnosed with COPD 10 years ago and is currently on long-term oxygen therapy. So he reports slight worsening of his exertional dyspnea and has no exacerbations, has not required hospitalization in the past year, not smoked cigarettes. On examination, the blood pressure is fine, heart rate is 80, and the respiratory physician wants consider listing this patient for lung transplantation. Which of the following findings would prompt the respiratory physician to list the patient for lung transplantation? This is another difficult MCQ. I've taken this because COPD, it can it can be asked why there will be a wide variety of options for the examiner to ask you regarding COPD. So they can connect COPD with the lung transplantation questions also. So it is better you read in detail about COPD. So for lung transplantation in COPD patients, the FEV1 should be less than 20% of predicted, and the DLCO should be less than 20% of predicted, or there should be a uniform distribution of emphysema throughout the lungs. So the FEV1 here given is 14%, so it is obviously less than 20%. So this is an thing which can prompt the respiratory physician to list the patient into lung transplantation. So there are some MCQs which can be asked on these topics also. Coming to smoking cessation, the patient they can give a clinical scenario where the patient is a pregnant female and she has already been given cognitive behavioral therapy for smoking cessation, which was unsuccessful. So what is the next line of treatment? They can ask you like that. So in that case, the ideal thing to do would be a nicotine replacement patch along with the short-acting nicotine replacement. So the patch should be given, and along with that, the short-acting other replacement therapies should be given. So the question can be asked on oxygen therapy. The important thing to remember in oxygen therapy is the target oxygen saturation in COPD patients, which is 88 to 92. You don't have to get the oxygen saturations to 100% in COPD patients because they are at a risk of hypercapnia. So 88 to 92% would be ideal thing. And coming to NIV, questions on NIV, we have discussed a lot. The indications of NIV and when to go for intubation at what pH and everything we have discussed. The fourth one is long-term oxygen therapy. The indications of long-term oxygen therapy need to be studied in detail. You have to remember those things, the PaO2 values, and if the PaO2 is 7.3 to 8, then what should be there to give long-term oxygen therapy is important. The next one is lung volume reduction surgery. In previous video, I have explained that one question has been asked, which patient is unlikely to benefit from lung volume reduction surgery, where the answer was non upper lobe emphysema and high exercise capacity was the answer. And there can be some other questions where the young patients who are non-smokers presenting with COPD. In that case, you can suspect alpha-1 antitrypsin deficiency. And there are some questions where they will be asking you the best way to grade the severity of COPD, the best way to diagnose COPD. So the best thing to grade the severity of COPD is FEV1 percentage, whereas the best thing to diagnose COPD is FEV1 by FVC ratio. So this is the difference between these two. And these are the MCQs that can be asked in COPD topic. So my upcoming video will be on pleural effusion, which is also very important. The analysis of pleural effusion and everything is important. So comment down if you have any doubts in this COPD topic, because it is very important to be clear with COPD. And comment down if you want me to take any specific topic, if you want me to teach any specific topic. And please like, share and subscribe to my channel, because these videos are free of cost, and it is I have to put a lot of effort to gather all the data and gather all the MCQs, put it together. So please support me and encourage me to do more such videos by subscribing to my channel. Thank you.